We are starting the last session, which will be dedicated to solid tumor and in particular mesothelioma and lung cancer with two exceptional speakers and investigators in the field. But the first speaker will be introduced by Dr. Cheryl Reeves, senior editor of the Lancet Oncology. Dr. Reeves.
Thank you. I'm delighted and honoured today to introduce Dr. Prasad Adusumilli, who's going to give the Lancet Oncology lecture. He just told me that after qualifying in India, he spent 4 years in Southampton, UK. Currently, he's a medical oncologist at the Memorial Sloan Kettering Cancer Center in New York and is an expert in the surgical management of cancers in the chest. His laboratory research focuses on tumour immunology and CAR T-cell immunotherapy for cancers. This includes combination immunotherapy to reactivate both CAR T-cell and endogenous immunity using cell-intrinsic and extrinsic checkpoint blockade strategies. The title of his Lancet Oncology lecture is CAR T Therapy for Lung and Other Thoracic Cancers. Please welcome him.
Thank you for the kind introduction, and I'd like to thank the organizers for the invitation. Before I start, I'd like to give my regards to the two mentors I had in my first job at University of Southampton, Mr. Colin Johnson and Mr. Jim Munro. When I approached them as a house officer to give me a small research project, they encouraged me and they gave me a small research project that led to this over a period of time. These are my disclosures. As you can see, I don't discriminate. I take money from anyone, everyone. So we heard a lot about and we learned, and I benefited a lot when I started working on the CAR T cells with Michal Sadline as my mentor, sitting next to CD19 gurus and hem-oncologists. I'm a thoracic surgeon, so my primary interest is in mesothelioma and lung adenocarcinoma. Shown here is a mesothelioma cell line being targeted by CAR T cell electron microscopy image, pseudo-colored. Those of you may not know much about mesothelioma. It's a regionally aggressive disease. It's a rare cancer. In the United States, about 2,000 to 3,000 patients per year. The characteristic of mesothelioma is 8 out of 10 patients we see in the clinic. It's limited to the one side of the chest. Metastasis is rare outside of the chest, only 2 out of 10 patients. It's not an immunogenic, low tumor mutational burden, low PD-L1 expressing among all the solid tumors. Elizabeth Zaffe group looked at 5,500 solid tumors. Of all of them, mesothelioma is the low mutational burden, low PD-L1. The patients develop morbidity because of regional invasion into crucial structures of diaphragm, heart, lung, and that's how they die. The median survival, combining adjuvant chemotherapy or induction chemotherapy, surgery, aggressive surgery, and hemithoracic radiation is about 12 to 18 months. Even recently approved checkpoint blockade therapy, dual immunotherapy, again, from diagnosis, survival is 12 to 18 months. Lung adenocarcinoma, even early stage with a curative intent to resection, 1/3 to 1/4 of the patients recur within 5 years. The checkpoint blockade that works in lung adenocarcinoma, non-small cell lung carcinoma, only works in 1 out of 5 patients. Other patients do not respond. So there's a clearly unmet need. So in the clinical trials, the solid tumor clinical trials are slowly catching. This review article summarized all the clinical trials and autologous and allogeneic. These are the tumor antigens that are being targeted by frequency among the solid tumors. So for our purpose, we chose to target mesothelin. It's a cancer cell surface tumor-associated antigen overexpressed in majority of the tumors. Postdoc Aurora Morello in our lab summarized, as you can see, in majority of the solid tumors, lung cancer, thymic cancer, ovarian cancer, pancreatic cancer, and GI cancers, majority of the solid tumors overexpress mesothelin. We have studied, in addition to overexpression, we want to target an antigen that is essential for the cancer cell aggressiveness. So we have shown in the preclinical models, mesothelin-expressing mesothelioma cells are at the invading edge, which is also what we see in the patients with invasion. In the lung adenocarcinoma, high frequency of metastasis, higher the mesothelin expression, higher the KRAS-mutated lung cancers, showing again association with aggressiveness. Within triple-negative breast cancer, patients expressing tumor-bearing mesothelin have a low survival, increased metastasis, decreased duration to the metastasis. In esophageal cancer, our pathologist Lara Tong came with an observation. Barrett's esophagus with acid reflux do not express mesothelin. But the moment it turns into high-grade dysplasia with malignant transformation, there's a cancer cell-specific mesothelin overexpression. The reason we did that was we didn't want to target just because it's overexpressed. We reasoned that if a cancer cell aggressiveness is associated with overexpression of an antigen, it's unlikely cancer cell will shed under immune attack, and that's one of the reasons. Studying this about a couple of thousand tumors helped us to design a CAR to spare the low expression in the pleura, peritoneum, and pericardium and target the tumor tissues. Many investigators, including us, selected a tumor antigen based on their expression patterns in the primary tumors, because stage 4 advanced cancers at the most get a needle biopsy. There's not much tissue available. TCGA that is repeatedly quoted, 90 to 95% of TCGA cohorts are in solid tumors, early stage patients, because that's where the tumors are available. Knowing that, we carefully collected the primary and matched metastases from the same patient, about 110, and we noticed that mesothelin is overexpressed in metastasis compared to the primary tumor of the same patient. About 2/3 of the lung adenocarcinoma metastasis express cell surface mesothelin, again attesting to the fact that it's probably associated with aggressive clones. Following the tissue mesothelin in a clinical trial is difficult. We need repeated biopsies. The serum mesothelin-related peptide. So we did a prospective studies in triple-negative breast cancer, esophageal adenocarcinoma, gastric cancer, to see any correlation. But unfortunately, there is no correlation between the serum levels of the mesothelin and the tissue mesothelin, except at very high levels. So I have noticed that serum mesothelin cannot be used for monitoring tumor regression, progression, or therapy response. We looked at the tissue mesothelin expression changes in esophageal adenocarcinoma patients by serial biopsies during their chemotherapy, chemoradiation therapy, following surgical resection. This manuscript, hopefully, we should be able to publish soon. But all this helped us not just selecting an antigen, but understanding this antigen expression and its associated immune changes in the immune microenvironment as well. These few thousand, 3,000 tumors and the serum samples we collected is not only used for mesothelin, but the new targets we are selecting, we go through this with clinical, radiological, pathological annotation to understand if this antigen is really associated with cancer aggressiveness. Having developed the first and second generation CAR T cells working with Michel Sadelain, initially we tested for in vitro antigen specificity, cytotoxicity. We moved on to in vivo. As I mentioned, the mesothelioma in our mouse model, orthotopic pleural mesothelioma, encircles the lung and the heart and the pericardium, exactly what I see in the operating room in patients. Here, we injected CAR T cells either systemically or intrapleurally. Intrapleurally, for the reason I mentioned, it's a regional disease. We thought that if we can activate the CAR T cells here, perhaps there's an advantage. What we observed in the publication, systemically administered single-dose CAR T cells prolong the mouse survival. But the intrapleurally administered CAR T cells, even when they're reduced by 30-fold, are able to prolong the survival and eradicate about half of the mice disease for more than 200 days. That's because we studied later with the T-cell bioluminescence imaging, systemically administered CAR T cell gets sequestered in the lungs. Regionally administered, intrapleurally administered CAR T cells avoid that sequestration, immediately antigen activated, thereby they proliferate. There's a dose expansion. Most importantly, we learned that antigen-activated CAR T cells acquire chemokine receptors that promote their infiltration into metastatic distant sites. They do circulate, they don't get sequestered. I have done oncolytic virus intrapleural trials before, where we notice oncolytic viruses are sequestered at the most 3 to 4 cell layers deep, and the immune system kills the virus, whereas CAR T cells immediately activated, they circulate. Most importantly, what we showed in this publication that's published back in 2014, CD4 CAR T cells typically lag behind CD8 CAR T cell activation. Because of immediate antigen activation, CD4s are able to provide better helper function, thereby CD8 numbers are increased and sustained, perhaps explaining some of the efficacy with intrapleural administration. Typically in this aggressive model with the diaphragmatic invasion, chest wall invasion, we give purposefully very low dose of CAR T cells, about 50,000 to 100,000 per mice. Again, remembering what we encounter in the solid tumors. At these low doses, when we further decrease the dose, we can see initially following intrapleural injection, tumors regress, but CAR T cells get exhausted expressing PD-1, and the tumors relapse. We have shown in this publication that by repeated administration of anti-PD-1, we can rescue the exhausted CAR T cells, prolong their efficacy, and achieve tumor eradications for a long time. That's what we published there. With that, we translated to clinical trial. Shown here is the first phase 1 clinical trial that's published last year. Again, these are the survival curves, intrapleural administration. Thanks to our interventional radiologist who come up with the techniques, because patients with mesothelioma, especially after surgery and radiation, are fused pleural cavity. There is no gap, there's no pleural effusion to drain and inject CAR T cells. But they developed special techniques which we published here. Thereby, there are no manufacturing failures among these patients. There are no infusion failures. We're able to inject intrapleurally. And combined with anti-PD-1 agent later in the trial, we have shown that it is safe at the most grade 2 adverse events. In some patients, we have seen complete metabolic responses, as we have demonstrated here for about 18 to 24 months. In addition, by analysis of pleural effusion in peripheral blood, we can see T-cell clonal expansion and epitope spreading as time goes by. The median survival of 18 patients among these 27 that received CAR T cells, and following that a month later, once we have established safety from CAR T cells, they received at least 3 doses of anti-PD-1 agent. We have shown the median survival is about 23.9 months from the day of the CAR T cell infusion. This is compared to phase 2 second-line therapies. The historical control shows about 6 to 9 months. Of course, at this time, everything was done with peer-reviewed funding. We don't have any pharma support. It was very difficult to get some money. So we carefully selected patients that at least can wait 1 to 2 months during T-cell manufacturing. But in this carefully selected patients, the median survival is 23.9 months. We moved on to the phase 2, where we systematically administered, after 6 weeks, anti-PD-1 to all the patients. Among the 41 patients in the phase 1, phase 2 clinical trial, which we are getting ready to write the manuscript with correlative science, more than 2 years, 13 patients are alive. At a median follow-up of 36 months, the median survival is not reached. Again, most of these patients received a single dose of CAR T-cell intrapleural, followed by anti-PD-1 agent, not any other therapies. Most importantly, in these patients in the peripheral blood, as I mentioned, they're injected intrapleurally, we can see the CAR T-cell persistence, about 100 days in 9 out of 10 patients, about 1 in 3 patients about to 200 days, 1 in 5 patients up to 300 days. We're able to see in the peripheral blood CAR T-cell persistence. One of the reviewers pushed back saying that your T-cells are not targeting the tumor, that's why they're just circulating in the systemic circulation. We accepted that criticism in the discussion, but I don't think so, because in a systemically delivered CAR T-cell trial, these are patients with triple-negative breast cancer, multiple lines of therapy, about 5 to 6 median lines of therapy. This is supported by Department of Defense, where we have systemically administered the same dose of CAR T-cells that we did previously intrapleurally in patients with mesothelioma. There are some responses, but transient, the disappearance of PET avidity in the lymph nodes, reduction in the size, but patient developed new metastasis. There is some CAR T-cell activation by systemic analysis of peripheral blood serum. You can see the cytokines at week 2, week 3, proliferation cytokines going up. But in this cohort, we did not see persistence of CAR T-cells at the most up to 30 to 60 days. Again, I don't think they're just circulating intrapleurally. They're activated. We now have some chemokine receptor data. Hopefully, we'll publish in the next manuscript. So what we believe is we talk about the cold and the hot solid tumors in the immunotherapy, even the cold tumors, by administering the CAR T cells, if we can promote tumor infiltration and lysis of certain cancer cells, this reduction in the tumor burden, altered immune microenvironment by secreted effector cytokines, perhaps provide a fertile ground for neoantigen release and priming within the tumor and tumor draining lymph nodes, which is the advantage with regional administration. And these neoantigen responses, endogenous responses, and CAR T cells exhausted can be rescued with anti-PD-1 strategy. Thereby, we can regress the tumors and perhaps achieve tumor eradications in the long run. This is what we proposed as one of the options for the solid tumors. But we do know in the viral literature, 3 manuscripts published in last year, August of 21, have shown that antigen-stimulated CAR T cells, upon chronic antigen stimulation, develop epigenetic scarring. Even to rescue, it's going to be difficult. Based on that, instead of giving anti-PD-1 following CAR T cell therapy, we developed a cell-intrinsic checkpoint blockade, which is a PD-1 dominant negative receptor, wherein the extracellular component of the PD-1 ligates to the PD-L1, L2 expressed by the tumor. We remove the intracellular signaling. It actually acts as a decoy receptor. Initial proof of concept studies were published. As I mentioned, there is no cell-intrinsic checkpoint blockade. And we tested that with 1XX, that's a mutation, the CD3 zeta, CD28 co-stimulated PD-1 dominant negative receptor CAR T cells. We developed a tumor treadmill test. I don't think from what we see in the solid tumors, simply eradicating the mice for a month is not going to be good enough, because these CAR T cells and immunotherapy is going to face heavy antigen burden, heavy tumor burden in the patients. So what we developed is a tumor treadmill test For example, here, following 60 days of tumor eradication, initial tumor eradication, we give increasing doses of cancer cells multiple times to re-challenge these mice. And you can see this PD-1 DNR, CD28 co-stimulated CAR T cells, mesothelin targeted, are able to resist tumor establishment, whereas the previous construct and the previous clinical trial, the M28Z CAR T cells, are not able to resist after a certain time, and the tumors are established. So functional persistence, I think Renier Brentgens previously alluded to, is always a debate, but in solid tumors, we believe the functional persistence is important rather than simple persistence. We translate that to clinical trial. To date, about 7 patients treated. Again, the first 2 cohorts, these are the doses. We know that the PD-1 dominant negative receptor is expressed by PCR for the extracellular domain. This has been safe in the first 6 patients. 7th patient died after 3 weeks, and now we have an autopsy. Thankfully, patient and the family members agreed for autopsy. We hope to publish the results, which provided tremendous insights that is not related to CAR or to the PD-1 DNR. We have not submitted to the data to FDA yet. That's why I'm not at freedom to discuss. But most importantly, in all these patients, following a single dose of intrapleural injection of a small dose of CAR T cells, you can see the persistence much better than the previous clinical trial. In the first 2 cohorts with a similar dose in the previous clinical trial, the CAR T cells we are able to see in the peripheral blood about 3 to 4 weeks. But here, up to 50 to 150 days, we are able to see in all these patients persistence of CAR T cells. Following with the analysis in the preclinical models and also the clinical trial correlatives from the tumor samples in the peripheral blood, we learned some other functions of PD-1 dominant negative receptor, which is not published yet. We do know it's promoting the functional persistence of CAR T cells. Anti-tumor efficacy in the mouse model is similar to anti-PD-1 therapy. But most importantly, even without the CAR, PD-1 dominant negative receptor transduced T cells are able to be retained in the tumor. We think it can act as a delivery vehicle to deliver cytokines or chemokines that we want in the tumor by using just PD-1 dominant negative receptor. Most importantly, because we are preventing exhaustion, rescuing from exhausted CAR T cells is one thing, but preventing exhaustion, the co-stimulatory domains are active, and we are able to notice the auto and trans-co-stimulatory functions in PD-1 dominant negative receptor CAR T cells compared to the ones without PD-1 DNR. Most importantly, the PD-1 DNR, although we are inserting into the CAR structure, is able to rescue even the TCR within those T cells upon TCR activation. So there are multiple, and in addition, these cells can be combined with anti-PD-1, anti-PD-L1, and anti-CTLA4, promoting the efficacy in the mouse models. So there are other advantages which we did not anticipate. Initially, our goal was to show that it can prevent exhaustion or rescue from exhaustion. But by preventing that, the T cells are able to upregulate the co-stimulatory domains, and this is also functional for the TCR, which we are getting ready to publish the manuscript. So all this infrastructure going back between the patient samples, understanding the correlative science from the intrapleural vaccinia trial, and the mouse models to develop an infrastructure and a strong foundation took us about 10 years. But now the last construct we are able to translate within 2 years from the construct to the FDA approval and starting the clinical trial. Hopefully we like to do that more with all the infrastructure that is developed. So one example I mentioned is the regional CAR T cell therapy. It is not applicable to all the solid tumors. Later in the talk, I will show you that can be expanded, but still not ideal. But where it can be done, we have shown in many publications, there are the clinical trials, already several of clinical trials with regional administration of CAR T cells and the preclinical models that are being translated. In all these models, the regional administration provides a window access, and these antigen-activated CAR T cells with promotion of chemokine receptors, unlike not getting sequestered in the lung, unlike in intravenous administration, they can promote regional immunity, and this also can provide the systemic immunity with perhaps better safety than intravenously administered CAR T cells. We compiled all the publications of clinical, preclinical, and recently wrote an article in the Cancer Cell promoting this regional CAR T cell therapy, how it's not just about delivery, but the immunological advantages we can see and achieve in solid tumors. What are the next steps? We heard a lot about hurdles in solid tumor cell therapy. I'm not going to go into the detail, one of which we are answering by administering extrinsic checkpoint blockade anti-PD-1 agent or cell-intrinsic PD-1 dominant negative receptor. We know tumor antigen heterogeneity, immunosuppression by macrophages, T regulatory cells, and the stromal hindrance are the major factors. This is a patient treated in the clinical trial. with the multiple metastases throughout the body, patient with mesothelioma survived more than 20 months following a single CAR T-cell infusion, anti-PD-1. But the reason I'm showing that is we are administering a CAR T-cell, adaptively transferred cell. We are asking them to go into the lung metastasis within the lung tumor microenvironment to reduce those tumor burden or eradicate, come out, go to the liver, a different microenvironment, come out and go to bone, a completely different environment. This is too much to ask unless we understand the immune microenvironment and what influences the cell therapy behind it in solid tumors, because the phase 1 clinical trials are done with patients as in any other cancer, advanced cancer patient that failed multiple lines of therapy and fortress of immunosuppression in the solid tumors. So we strongly believed from the beginning, understanding the tumor immune microenvironment is essential, understanding the battlefield where we are sending the soldiers. So systematically from the get-go, we collected 6 tumor cores, 3 stromal cores. We developed tissue microarrays because cost-effective rather than doing individual slides from the patient. To date, we analyzed about 5,500 patient solid tumors. As you can see, lung adenocarcinoma, mesothelioma, squamous cell cancer, esophageal cancer, that were many of which we published. Of course, this is the primary tumor, stage 1 to stage 3, where the resected tumors are available. We now developed a lymph node bank, about 650 lymph nodes, normal, micrometastatic, macrometastatic lymph nodes, to understand what is happening in the lymph node tumor environment. I already mentioned about metastatic patients. So there's the intra and intermetastatic heterogeneity we're trying to understand, at least in the available samples. That is, this is the group of patients that we analyzed. This is one of the patients I operated. As you can see, the CD8 T cells are sequestered in the stroma. So understanding the tumor microenvironment, being a translational person, is very important to me. That is mimicked in our mouse models. So in our mouse models, we purposefully inject a small dose of solid tumor cells, allow them to establish, develop stroma, and accumulate tumor-associated macrophages. It's very easy to inject 1 million cancer cells after a tumor burden establishment to show that we eradicated the tumor, but that's not going to be the real life. So understanding this tumor microenvironment helped me to develop mouse models that are clinically relevant. But still, these are immunodeficient models. We do have syngeneic models that we test these CAR T cells. But I think there are modern techniques that we need to understand that can be included in the research. Until now, as surgeons and endoscopists, we look at from the tip of the endoscope. That's where the camera is. But now the robotic technology, there's a shape sensing technology where every few centimeters they established sensors, and each sensor talk to each other. So in real time, as you can see here, the entire movement of the catheter, not just the tip, is given to the surgeon or the endoscopist. So using that, we perform now robotic bronchoscopy, where it's a simple procedure. Using the robotic guided navigation, we can go to any corner of the lung and take the biopsy guided by this navigation. So it's not uncommon in my practice. Every week in these patients, I go biopsy 2 to 3 tumors in the right lung, 3 tumors in the left lung, every single lymph node with minimal morbidity to the patient. Because we are doing the biopsy from inside the organ, the morbidity is much less. It takes me a couple of hours, and patients go home on the same day. So we have convinced the pharma industry to understand their agents. It's important to come to early stage tumors where we can biopsy all these multiple normal lung tumor nodules on both lungs and lymph nodes prior to immunotherapy agent, give a single dose of immunotherapy agent, go to the operating room, resect. Thereby we have tumor, blood, and the lymph nodes. And we hope to start 2 clinical trials that are approved by the end of the year, where we can inject in an induction setup immunotherapy agents and study the tumors that are resected to know more about the myology. And the second thing, we established a culture system, EPEX or ex vivo pleural effusion culture system, and we are doing the same thing with ascites as well, where typically from in vitro we do mouse studies, occasionally primate studies, and go to clinical trial. Instead, we develop this pleural effusion. As some of you may know, many of the solid tumor patients, about 150,000 per year, United States, develop pleural effusion. They get drained this fluid anywhere between half a liter to 2 liters. And this fluid is full of T regulatory cells, IL-10, macrophages, normal mesothelial cells, mesothelioma or lung cancer, breast cancer, cancer cells. So we established a culture system where we test the next generation CAR T cells with a severe immunoinhibition. Obviously, it's not resembling the solid tumor, but it's close to without using the mouse system, where we have shown even with just a supernatant, with no cells, when we incubate the same CAR T cells, with the RPMI, you can see beautiful cytotoxicity, but 3 different pleural effusions from 3 different patients, you can see the immunoinhibition. By analyzing these pleural effusion samples, looking what cytokines are there, what could be causing this inhibition, we are learning a lot, not just the typical IL-10, TGF-beta, PD-L1, PD-1 soluble. We are analyzing and learning other factors that is providing insight, and we are doing the same thing for gastrointestinal cancers with ascites. So I think this kind of human tumor immune microenvironment and these biopsies, we can take core biopsies, develop organoids, which we are in that process. So I think provides an alternative system from mouse to human beings before translation in solid tumors. Tumor antigen heterogeneity is another hurdle that we talked about. Again, any of the antigen, tumor-associated antigen, when we develop CAR T cells, we need to target the tumor cells and spare the normal cell expressing low levels of antigen, which is very difficult, as Dr. Brendt has alluded this morning. And the heterogeneous antigen expression is seen. These 4 cores are from a single patient. So you can see, even among the patient that is expressing mesothelin, the antigen expression density, intensity, and distribution is not the same. And we do know the typical CAR T cell second generation, we test antigen high, you get a good survival. Antigen low, they are not that effective. As I mentioned, by studying the different stages of lung cancer, we do know as the cancer advances, the mesothelin cell surface expression is high. Now, using these models and using these tumor samples, we are testing the multiple combinations of antigen where we can target majority of the cancer cells in a given solid tumor lung cancer patients. In addition, we have developed a new co-stimulatory domain that are CD28 IL-2 independent interferon gamma mediated that are much effective against low antigen expressing tumor cells, still keeping the selectivity, and we hope to conduct IND studies and translate in the near future. But antigen expression, whenever I talk to the biotech, there is so much focus on the antigen, which antigen should we target, what should be the cutoff for the clinical trials. But I am not convinced that alone can be that is an important criteria, but that alone is not the sole criteria in solid tumors. For example, these patients with mesothelioma, you can see extensive tumor burden. Typical lifespan is about 3 to 6 months. This patient had only 25% of mesothelin expression. Following injection of the intrapleural CAR T cells and following anti-PD-1, you can see this patient showed response by MRECIST criteria, complete metabolic response within 3 months, serum mesothelin levels remained at normal level, patient gained weight and up to 500 days is able to maintain the weight without any additional therapy, but continuation of anti-PD-1. We can see epitope spreading in these patients following 32 weeks when we did the biopsy compared to before the CAR T cells, where you can see extensive tumor cells. There are isolated tumor cells sequestered in the stroma, but majority of the cancer cells were eliminated. So I think with a patient with endogenous immune responses, when we provided the boost, again, talking about the initial tumor studies I have shown, the tumor immune microenvironment, although they differ, the type of cells differ between the solid tumors, it's always the balance between inhibitory and effector response. When the balance is tilted even slightly in a multivariable analysis where we included every clinical, radiological, pathological factors, this just tilting the balance is shown to be prognostic and favorable. I think if we can do that in solid tumors, at least in a proportion of patients with a good endogenous immune response, if we can tilt the balance and then provide some checkpoint blockade to rescue the exhausted CAR T cells, endogenous T cells, I think this can result in survival benefits or at least prolonged lifespan as shown in this patient. Recently, we published in lung cancer with adjuvant chemotherapy. Yesterday there was a question about how can we employ the chemotherapy or radiation therapy. As a translational person, it's extremely important to me somehow to fit into the standard of care, which is a little bit easier to translate than to come up with a completely new paradigm. So we looked at the chemotherapy of the available samples. Patients with stage 2 and 3 lung adenocarcinoma typically receive adjuvant chemotherapy to eliminate any residual disease or micrometastasis that are distant. These patients, the adjuvant chemotherapy benefit is only 5 to 15%, but that's the standard of care because there's nothing else available. But when we looked at these tumors, more than about 500 tumors, only in immune-activated tumors, we defined them as PD-L1 expression on macrophages only, tumors only are tumor and tumor-associated macrophages. Only in these immune-activated tumors, there is a chemotherapy survival benefit. If there is no PD-L1 overexpression, there is no survival benefit. Among this, patients with MDSs in the stroma, this difference in the survival is much more pronounced. So we are conducting prospective studies, serially collecting pre-induction samples, resected samples, and post-adjuvant chemotherapy peripheral blood as well, to check for MDSCs in the peripheral blood and the tumor-associated macrophages in the tumor to understand the mechanism. But this gives us some hope that perhaps in this patient population, we can avoid chemotherapy in a certain groups of patients. And while we are developing chemoimmunotherapy, which is coming into the induction setup in solid tumor patients, we can make rational-based strategies than simply combining them. And if this is true, if solid tumor is somehow eradicating these macrophages in this micrometastasis, it provides insight into the bridging therapy. With autologous CAR T-cell therapy, we know we have to wait about 6 to 8 weeks for manufacturing. What's the best bridging therapy? And that's where we believe understanding these mechanisms of chemotherapy can be useful. So not only we can decide the bridging therapy, but we can fit in the paradigm of standard of care for the current patients. So I mentioned there's a lot of focus on the antigen alone and what's the antigen expression cutoff, but I think we all know what we are dealing with, the Hydra of multiple heads and multiple obstacles in the solid tumors. And most importantly, each obstacle is not a constant, it is dynamic. When we try to reduce the macrophages, something else the tumor is doing. When we try to cross the stromal barriers, it's bringing macrophages. When we solve this, TGF-beta is upregulated. So I think it's a dynamic process what we are against in solid tumors. So some high-risk approaches that we are doing in the lab, we talked about the lymphodepletion. Dr. Brennan mentioned that repeated lymphodepletion is not possible because it's going to kill the cancer cells, cyclophosphamide and fludarabine. So can we do the lymphodepletion in vivo, selectively target a set of T cells, so constantly 1/3 of the T cells are eliminated, endogenous lymphodepletion, thereby providing space for the administered CAR T cells to engraft and proliferate. High-risk approach, but we are ready for the IND studies. Similarly, the next generation CARs, we learned the low-affinity CAR T cells can do very well against hematological malignancies, and the PD-1 upregulation is low, whereas the high affinity, they're able to kill only the solid tumor cells with a high PD-1 expression. So we are testing both low and high affinity CAR T cells for the next target. As I mentioned, the co-stimulated domain has been promising in solid tumor setup against TGF-beta enriched tumors that we are conducting IND studies. Others I already mentioned, targeting macrophages and how to bring chemotherapy, radiation therapy into the clinical paradigm. All this I was able to do. I can't list even the names and the pictures, as you can imagine. Several postdoctors. I specifically like to mention Bob Ginsberg, who inspired me to be a thoracic surgeon, the father of thoracic surgery in US, and not only to do surgeries, to become a surgeon scientist. Michelle Sadline, whom I started Human Fong, who gave me an opportunity as a resident to train Isabel Rivera, whose facility manufactures all the CAR T cells. Renier Brennergens, we heard him before. What you don't know him is the unconditional support he provided me. As a surgeon entering the field, doing the research, doing the operating room is not easy. He provided an unconditional support and leadership for me to do this and to learn from the CD19 gurus, several of my colleagues, research faculty, and the funding support. Thank you.